Hello guys, so today we're going to continue surgery review for CMS Form 3, and last time there is one previous video in which we did the first uh, four questions, first three questions for surgery, first three questions for surgery, and we couldn't do more in that video, so now we're just going to continue from the fourth question and we'll try to do the 10 questions of the CMS Form 3. And like I say, that you're supposed to do these uh, before or after doing your CMS forms, it wouldn't matter because the questions are rephrased and inspired from the paper. So it wouldn't really affect your performance in any way. What you have to do is if you're watching this video, you need to completely grasp the concept that is being explained to you, right? So let's move on. So this is the question number 4, which says that what is the most likely diagnosis? 52-year-old man, previously healthy, reports 3 months of lightheadedness and hunger occurring late in the afternoon, before dinner, and after heavy exercise. Eating or drinking something sugary relieves his symptoms. 2 weeks ago, he nearly lost consciousness while running. Symptoms improved after consuming fruit punch. His only medication is daily low dose aspirin. His He drinks 1 to 2 glasses of wine nightly, does not smoke, and has no illicit drug use. His father has type 2 diabetes, physical exam, height 183, weight 77, BMI 23, pulse 60, BP 105, by 60 otherwise normal. During a supervised fast, he develops hypoglycemia after 7 hours. Serum glucose is 25 with elevated serum insulin and C-peptide. So honestly, I think the most important part of this question is in the last lines. And they're simply asking for the diagnosis, so this should be easy. Now, they would sometimes give you the height and the weight and not the BMI. Now, they can do this in the NBMEs, but I've never heard this happening in the real exam. So, what they're basically trying to do is they're giving you the height and the weight only. They expect you to sort of get the idea of BMI yourself. That's why they don't mention the BMI in those cases, but I have not heard of this being done in the real exam. So this is a man who is facing hypoglycemia again and again, right? Typical symptoms. So I'll give you a moment to answer from this, and then we'll move on. All right. So the man is having repeated attacks of hypoglycemia and is has has elevated serum insulin and C-peptide. So the answer would be insulinoma. Why is it insulinoma? Let's look at that. So the definition of insulinoma is that insulinoma is a pancreatic beta cell tumor causing endogenous hyperinsulinic hypoglycemia. So that explains the high serum insulin and C-peptide. So if both are increased, which means that serum that there is an insulinoma, there is an increased secretion of insulin. If both of these are increased, if one of these is increased, let's say if only serum insulin is increased and C-peptide is not, it means that the patient is injecting himself with insulin exogenously, right? That would go into factitious disorder territory. But now, since both of them are increased, so this is insulinoma. It's quite easy question. Classic presentation is the Whipple triad, symptoms of hypoglycemia, which says that there would be neuroglycopenia, which simply means that there would be neurological symptoms of hypoglycemia, such as lightheadedness, confusion, syncope, documented low plasma glucose, and symptom relief with glucose. So this is the Whipple triad. All of this symptoms of hypoglycemia, uh, low plasma glucose levels, and symptom relief with glucose. So this is the Whipple triad. You are supposed to know this. And typically, fasting hypoglycemia. Uh, so the timing is that this is typically a fasting hypoglycemia. A postprandial hypoglycemia is less common. So you wouldn't really have hypoglycemia after eating something, but uh, in a in a fasted state, he would uh, be hypoglycemic. So this is a history point. You need to be careful that they will give you the timing in history. In labs, we would have hypoglycemia with inappropriately high insulin, C-peptide, and proinsulin. And there would be negative sulfonyl screen. So sulfo sulfonylureas cause hypoglycemia, right? And sulfonyl ureas can also cause high insulin and C-peptide levels because they increase the production of insulin. So they can mimic insulinoma, but the difference would be that the patient would be taking a sulfonylurea, right? But this patient does not take any sulfonylurea, any medicine. So that would be a difference. That would be a key difference in the history, right? So you need to keep that in mind that sulfonylureas do mimic insulinomas. And associations can be sporadic or a part of MEN1 syndrome, which is very important that it can be a part of MEN1 syndrome, along with hyperparathyroidism and pituitary tumors. So by imaging, we can get CT, MRI of the pancreas, and we can also do endoscopic ultrasound of, for localization. The treatment is surgical resection. We can medically manage it, but the first treatment of choice is surgical resection. And then, if you want to medically manage it, you can give the patient diazoxide or octreotide if the tumor is unresectable. So, why other options are incorrect? Adrenal insufficiency would cause fasting hypoglycemia, but would also cause hypotension, hyperpigmentation, insulin, and C-peptide will not be elevated. Insulin and C-peptide would not be elevated. Hyperpigmentation would be there. Cushing syndrome, hyperglycemia, not hypoglycemia, cortisol excess. Exogenous IGF production, which rare, causes hypoglycemia, but usually low insulin and C-peptide. And reactive hypoglycemia occurs within 4 hours after meal, so not during prolonged fasting and not appropriately elevated during fasting. So this is basically what they call as what what they mean by reactive hypoglycemia is basically when you go into a food coma sort of a situation, right? When you feel quite sleepy after a food. So this happens when you it doesn't it's not really a physiological phenomena, but it happens when you consume a lot of a diabetic diet. Surreptitious insulin use is basically fat tissue disorder because they're using insulin. Hypoglycemia with high insulin and low C-peptide. Pituitary insufficiency can cause secondary adrenal insufficiency, would not elevate insulin. Type 1 diabetes mellitus causes hyperglycemia and risk of ketoacidosis, not fasting or hyperinsulinemic hypoglycemia. So that's how you can differentiate between all the other options. Your educational objective is to basically, you need to know what the Whipple triad is, you need to know the association of insulin and C-peptide levels, and you need to distinguish it from other situations such as surreptitious insulin use or sulfonylurea use. You need to be able to distinguish all of them. There is a mnemonic that I found, which is insulinoma. So through insulin, part of the insulinoma, there's a mnemonic of inappropriately high neuroleptic symptoms, symptom relief with underlying hypoglycemia, late fasting. You can see the starting initial matches the alphabet in the spelling. So you can remember this. Take a screenshot, maybe if you like it. All right. So associations. Main one, of course, this is the main one that you need to remember. This is important, and need to differentiate from sulfonylurea-induced hypoglycemia. So both of these would be high. So you need to differentiate between that. right? Yeah, so this is basically uh, insulinoma image. So this is an endoscopic ultrasound, and this is a CT image. So if you could see that this might be a bit difficult to identify the ultrasound one, but this one you could see that there is this tumor that I highlighted here in the pancreas. This is the pancreas, and there is this tumor that you can understand. So this is what could be your insulinoma, right? So I just wanted to put an image here so that you could have an idea, and I'll take this off, and you can see. Okay, this might be a bit difficult to identify, but you can read the description here also. So ultrasound might be a bit difficult, but this you can identify easily. All right, so moving on. 25-year-old woman presents 48 hours after developing sharp pain in the upper outer quadrant of her right breast. Pain is gradually improving on exam. There's 2 centimeter tender area in the same quadrant without a palpable mass. Next step in management. So I'll give you a moment to do this. All right, so she's 25 years old. She has sharp pain. She has a tender area in and a palpable mass. So I hope you kept in mind the age. Uh, excuse me. Kept in mind the age of the woman before choosing an answer. So let's go ahead. And you do reassurance, right? And I am sure most people marked mammography, but reassurance is the answer because what she is basically uh, experiencing is nostalgia, which is breast pain. Obviously, they've told you in the question. So this is common in young women, and it's often cyclic or non-cyclic. Doesn't really matter. You don't need to mention that into the question. But if it's a young woman and she's having breast pain in a focal area uh, without a palpable mass, without a palpable mass, then there is nothing really. 90% of cases, there is nothing really to worry about. It's benign. So, a fact that you must remember is that acute focal tender areas without mass in women less than 30 are usually benign. Fibrocystic changes, trauma, localized infection, whatever the reason being, they are usually benign. So, this is a rule that you must know. So, management in women less than 30 is first step is to clinically observe and reassure for non-mass related focal tendencies. And then you do imaging only if a mass is present, palpable, persistent, or has some suspicious features. So even if the woman is less than 30 and a mass is present, you do not reassure the patient. Although in majority of the cases it is just a fibroadenoma, it is benign, you don't really need to do anything else. But you need to do ultrasound. Imaging is always done if there is a mass, always. But if there's not a mass and the patient is young and she's having focal pain, then you're not supposed to do anything. And red flags requiring imaging biopsy, persistent mass, nipple discharge, skin changes, lymphadenopathy, or age greater than 30 with risk factors. So I'll say this, and this is what you need to remember. And this also. These are key facts that you must remember. These are some kind of rules that you must understand and remember, right? So why other options are incorrect? Mammography is not first line in women less than 30 for acute mastalgia without mass, or even if there is a mass, they're not really first line for women less than 30. MRI of the breast is not really a first step in any question of USMLE. MRI of the breast will not be the first step in any question. And it's just reserved after doing biopsy and everything, then you do MRI. So this is the third line be fourth line. And then antibiotic therapy, not indicated, no signs of infection, erythema, fever, fluctuance. This would this would you would give antibiotics if there's a signs of an abscess formation. And biopsy is not necessary because there is no mass. So educational objective, acute self-limited focal breast tenderness in young women without a mass should be managed conservatively with reassurance. Avoid unnecessary imaging, antibiotics, or biopsy. And there is also a mnemonic for you guys since you like mnemonics. So tender, tiny, transient, treat with tranquility, right? So tender area, small size, brief duration, reassure. Also, you must remember that in the question, the patient had pain since 48 hours, so it wasn't really a lot of time for till the diagnosis. So correlated fibrocystic changes often tender cyclical. So fibrocystic changes also are tender cyclical, but they can present as small masses throughout. So just because fibrocystic disease has been mentioned a lot in this question, I attached a histological image of it here. And the best way to, I think, identify it is that the question would be of a breast condition. And then if you see this picture, you must identify these islands. These are, this is known as adenosis, right? And this, everything in between is just fibrous change, right? So these are small cysts. These are cysts. And this is fibrosis. So if you can keep in mind and remember and can practice from a few histologic slides from Google, I think you'll get it. Right, so these are cysts. This is a cyst. And again, this, this, and this is fibrosis. Right, I hope you can understand. Right, this is the dark pink color. It's fibrosis. Right, so moving on, a 16-year-old girl presents to the ED 30 minutes after a stab wound to the anterior neck. A large pulsatile hematoma is visible at the level of the thyroid cartilage and is expanding. Most appropriate initial management. So I'll give you time to get this done. All right, so I hope you focused on the aspect of its expanding, right? And it's asking the most appropriate initial management. So I hope you read the options and focus on that. And the most initial management is endotracheal intubation. And why is it so? Because it's a penetrating neck trauma. So first of all, you'll do your ABCs, and then if they mention something, if they mention both of these in this question, but if they mention any one of them, that it is an expanding hematoma or pulsatile hematoma, so that hematoma is most likely to compromise the airway. If you just let it expand, it's just going to compromise the airway or can result in a tracheal or vascular injury. So you need to secure the airway first because it's just going to compromise. You can't really perform a surgery in a hurry. So you need to secure the airway. So you might have some more time to perform the surgery, or else the patient would get compromised. So the initial step would be to secure the airway, right, before definitive imaging or surgical exploration. It is a part of the primary survey. What is the primary survey? The primary survey is this. Forgive me. The primary survey is this, right? The ABCs are your primary survey. So this is a part of securing the airway is a part. Securing the airway is a part of your primary survey, right? So airway management, you prefer oral tracheal intubation if possible, or you go for cricothyrotomy or tracheostomy if the intubation fails. Now, if in a question they say that you have tried intubation and it has failed, so they will give you an option of trying it again or going for cracothyrotomy. And you should be choosing cracothyrotomy because you don't try again and again. If you tried once and it fails, then you go ahead and do cracothyrotomy. You're not supposed to be wasting time at that moment, right? Other evaluations, imaging, esophagoscopy, laryngoscopy are secondary and only after airway is stabilized. Why other options are incorrect? Barium esophagography delays airway management, so it's not really the initial management. Esophagoscopy, again, it's not really the initial management. Indirect laryngoscopy, again, not the initial management. Tracheostomy, only intubation fails. Primary approach is orotracheal intubation. So if they mention that it has already failed, you go to tracheostomy directly. You don't wait for anything. Education objective in parentetic neck trauma with expanding hematoma, imminent airway compromise takes priority. Secure airway immediately before imaging or definitive surgical repair. Mnemonic association, airway always first, and expanding hematoma with heart cartilage, think anterior neck vessels or trachea at risk. Those are quite easy questions today so far, nothing too difficult. And moving on, 57-year-old woman presents with a 3-month history of cough, recently worsening, and one episode of blood tinged sputum. She has a 40-pack year smoking history. Exam shows coarse bronchi at the right lung base. Chest X-ray reveals a 3 centimeter right hilar mass. Bronchoscopy confirms a non-small cell lung carcinoma. Mediastinoscopy and PET scan uh, show no metastasis. Preoperative pulmonary testing, left lung, FEV1, 600 ml, and maximum voluntary ventilation is 50% of predicted. DLCO is 50% of predicted, and AVGs is CO2 is 44, PO2 75. Which parameter is the most predictive? The post-operative risk for pneumonectomy. So I'll give you an option, some time to figure this out. All right, I hope it's done. So the answer is FEV1, right? Now, you can do this two ways. You can know a formula for this and do this, or you can know a simple fact, right? Simple fact is you can use logic in this kind of question. So FEV1 is the measure of its expiration, right? It's the measure of uh, expiration in 1 second. This is a formula that we use in the LFTs, right? We use FEV1 as a variable in the LFTs. So if there is something that we use in the liver function test, don't you think it might also be used to look for the risk after pneumonectomy? Because when you're cutting out a piece of lung, which pneumonectomy you're just cutting out a piece of lung, right? In pneumonectomy, you're cutting out a piece of lung. So after cutting out a piece of lung, what you're basically doing is you are checking for lung function, right? How are the lungs functioning? So it's sort of a LFT after doing pneumonectomy. So this kind of question popped up in front of me in the exam, and for the first time, I didn't know this, so I would use this logic. Everything else is not used in the LFTs, right? But if you want to do it uh, in as an easy way, you can also remember the formula. So FEV1 is the single most important predictor of post-operative pulmonary complications and mortality. Predicted post-op FEV1 is calculated using this, and you're not supposed to remember the whole formula. You're supposed to remember that the post-op FEV1 depends on the pre-op FEV1, right? So if this goes up, then this would already be up, right? These are directly related. That's what I've tried to explain to you in a concept that FEV1, let me do it over here. So FEV1 is equal to the LFTs, right? So if you want to understand the lung functioning post-operatively, then you are basically saying, I want to see the FEV1 post-operatively. This is both the same thing. Now, if you want to see the post-operatively FEV1, you must see the pre-operative FEV1. So you can either remember this formula or you can remember the logic, whichever seems easy for you. Uh, it also depends on the number of lung segments resected, obviously. It depends on this also, but they have never asked this. So, but keep in mind, they might, right? So remember this formula. Take a screenshot if you want. So threshold is post-operative FU1 greater than 100, 800 ml, low risk. So this is not really important. They don't ask for values. DLCO predicts gas exchange and exercise tolerance. It's used in conjunction with FEV1, but it's not really that important. And MVV is less predictive. ABGs are not really reliable for pulmonary function because uh, they they don't really they're not really sensitive predictors. If baseline is already normal, they cannot really predict a problem in it later on. Why are other options incorrect? Again, PSO2 is elevated, does not predict surgical risk reliability. Oxygen also does not predict a post-operative outcome. DLCO can give an information on gas exchange, but again, not on the functioning of lungs. And MVV reflects ventilatory capacity, but is inferior to FEV1 for risk stratification. Assesses post-operative pulmonary risk for pneumonectomy primarily using FEV1, calculating the predicted post-operative value. So that's what this is, right? I hope you understand. This question really had nothing other than the fact that you must know this fact. 26-year-old woman presents with worsening intermittent abdominal cramps, intermittent diarrhea, and 5 kg weight loss. Exam shows moderate generalized abdominal tenderness, hyperactive bowel sounds, and a tender mass in the right lower quadrant without involuntary guarding. Barium enema shows findings consistent with the underlying pathology, most likely diagnosis. So I'll give you some time to solve this. Alright, so I hope it's done now. And the answer is Crohn's disease. So why is it Crohn's? So chronic transmitted inflammatory bowel disease that can affect any part of the GI tract, commonly terminal ileum and colon. Clinical features: intermittent abdominal pain, diarrhea, sometimes bloody, weight loss, fever, and right lower quadrant mass palpable. It can also be pain. Sometimes it mimics appendicitis, but the history will give you a clue. So extraintestinal, it can have arthritis, uveitis, erythema nodosum, very important, primary sclerosing cholangitis. So I would say all of these things are very important for you to understand. The clinical features of Crohn's and ulcerative colitis are very important to understand. So they have given a tender mass in the right lower quadrant without involuntary guarding, right? And they've also given intermittent diarrhea, and they tried to make this a bit difficult, but tried to make this a bit difficult. But I think looking at the options, it's quite easy. They haven't given appendicitis here. Right. So barium enema findings, you'll get a string sign, which is a narrowing of a terminal ileum due to inflammation and fibrosis. It also has skip lesions, cobblestoning, strictures, complications being fistula, abscesses, strictures, malabsorption, increased risk of small bowel adenocarcinoma. Diagnosis: clinical plus imaging plus endoscopy with biopsy. And management was corticosteroids for acute flares and immunomodulatory agents for maintenance surgery You'll be giving these when there is a chance of fistula, right? So you'll be giving this, the azathioprine and adalimumab and those kind of infliximab, those kind of beautiful medications for fistulas and abscesses. Fistulas, most probably. Why other options are incorrect? Enteritis usually affects colon, causes by bloody diarrhea, no right lower quadrant mass. Other history might be present. Leiomyosarcoma is rare, it's usually painless. So no chronic diarrhea or weight loss pattern. Necrotizing enterocolitis is a neonatal disease, not adult, and its subsection is more common in children. In adults, it can occur due to a tumor or acute obstruction, but it doesn't really cause weight loss or diarrhea. So, education objective is this is Crohn's disease, a young adult with chronic intermittent diarrhea and right lower quadrant pain and weight loss and palpable mass, and you need to identify the string sign on the barium enema. Right, so I couldn't really find the string sign on barium enema, and the picture given in this paper also is very vague. So I could not understand it myself at that time. It didn't really show any string sign, but I did find a picture of cobblestoning. So I think something is better than nothing, and you have to differentiate it from UC, as it has continuous chronic involvement, bloody diarrhea, and no script lesions. So as you can see, this is completely a single segment, right? And yeah, so as you can see, this is completely a single segment, and this then goes ahead. And I think this is a picture of, it's not a picture of Crohn's. This is a picture of ulcerative colitis. So I just wanted to have that difference here. This is UC for anybody wondering, right? This is UC cobblestoning, right? Cobblestoning can occur in both, uh, primarily in Crohn's, but because this has skip lesions, you can see. So this is UC, right? This is a normal mucosa. Only this part is affected. So this is UC. In both cobblestoning can occur. It's not a specific feature, right? So 57-year-old man reports 3 months of progressive worsening calf pain with walking more than a half mile, relieved by 5 minutes of rest. He has 40 back year smoking history and 10 years of well-controlled hypertension. And those are the vitals. Exam shows slightly decreased popliteal dorsalis pedis and posterior tibial pulses. Femoral pulses are normal. Achial brachial index is zero point 0.8. Beyond smoking cessation, what is the most appropriate next step? I'll give you some time to do this. Okay. So you recommend a walking program, all right? Not aspirin therapy, uh, not a angiography, just a walking program, right? They made these options quite easy, right? They could have been anything else, slostazole, something to confuse the students, but no, they've made it quite easy. So walking program is the first line management of peripheral arterial disease, right? That's the first line management. The clinical features are exertional calf pain, relief by rest, ABI from zero point 0.5 to zero point 0.9 indicates mild to moderate PAD, decreased distal pulses, and normal proximal pulses. So that's what is mentioned in the question. So femoral pulse is normal. Just to keep in mind all of this. Management first line is walking exercise program, and secondary prevention is of course smoking cessation, antiplatelet therapy. After this has been done, of course, then you go towards this smoking cessation, antiplatelet therapy, aspirin, clopidogrel, statins, and then last is revascularization. That's the last line option. Slostazole is not really something they would want you to choose. Why are the options incorrect? CT lumbar spine is considered for neurogenic claudication. Pain and PAD resolves with rest. regardless of position. In neurogenic claudication, position would be important. So change in position would resolve the pain. MRI of the calf is really unnecessary. It's not done anyway. Aspirin therapy is recommended as secondary prevention, but does not relieve claudication symptoms. So exercise is the first step for symptom improvement, right? They've asked what beyond smoking cessation, what is the most appropriate next step. So they've also given this big hint, right? And aortic angiography is reserved for patients with severe symptoms or planning revascularization. It's not first line. So yeah, so ABI from zero point 0.5 to zero point 0.9 really just signals towards PAD, right? There's a mnemonic here, and you have to differentiate from neurogenic claudication because PAD pain is relieved by rest regardless of the posture, right? Spinal stenosis, also known as neurogenic claudication, is relieved by leaning forward. A 77-year-old man presents with 5 days of intermittent confusion worse this morning. He has a long history of alcoholism and has been forced to decrease alcohol intake over the past 6 days. He takes no medication. Exam mildly lethargic. Pulse is 80, BP is 166 per 92, otherwise unremarkable. Mental status exam is 27. These are the labs, and CT shows findings consistent with chronic changes from alcoholism. More appropriate next step. So this is a bit tricky question. Uh, Go ahead and look at this. Right. So this is basically we'll do a craniotomy. Why? First, let me explain the findings of the question. So macrocytic anemia due to alcoholism. Uh, he has a normal status exam, which means uh, he's not going to be on anticonvulsant therapy. He has no history of epilepsy, right? And he has 5 days of intermittent confusion, which is increasing. He has also, of course, alcoholism, right? So this is looking like a patient of subdural hematoma. So chronic alcoholism can give rise to that, right? There is no mention of benzodiazepine. We won't really give him benzodiazepine uh, if he's in confusion. We don't give benzodiazepine, right? So let's look at the explanation. So chronic subdural hematoma, commonly in elderly patients, especially those with alcoholism, brain atrophy increases subdural space, predisposing bridging veins to rupture. Presentation is gradual or intermittent confusion, headache, sometimes focal neurological deficits. Symptoms may worsen after minor trauma or spontaneously. CT scan shows a crescent-shaped chronic collection. So I have a picture here. So as you can see, this is quite an easy picture. They won't really give this kind of a picture in paper. They'll give a more subtle picture. So this is a crescent-shaped uh, mass sign showing subdural. Right. So CT shows a crescent-shaped hypotense, chronic collection over the cerebral. Hypotense means dark, right? Which the picture I showed you, it was white, it is hypertense. So chronically, it would be dark, may be present. Symptomatic or large hematomas, surgical evacuation is done, butthole drainage or craniotomy. Both of these could come in your paper. So remember both of these. Small asymptomatic hematomas may be observed, complications, midline shift, herniation if untreated. Why other options are incorrect? Anticonvulsant therapy, of course, there are no seizures. Benzodiazepine therapy would worsen the mental status function and respiratory function. IV magnesium sulfate has really no role in chronic subdural hematoma, and lumbar puncture is contraindicated because if the ICP is increased due to a hematoma, you will not do a lumbar puncture. Always do CT before lumbar. So CT before lumbar puncture. So this would be done first, and if there is no increased ICP, then you will do lumbar puncture. In elderly patients with intermittent confusion, especially with history of alcohol use or minor trauma, suspect chronic subdural hematoma, confirm with CT unperformed surgical evacuation is symptomatic or causing mass effect, right? The other part that this question can present is they can give you a fall history in the elderly. So fall history, this is fall, history of falls, right? Or alcohol, like in this question. Okay. And this is associated with brain atrophy and minor head trauma. So brain atrophy can also signal towards dementia, but the mini mental status exam, which is the MMSC, was normal. So this was not dementia, right? If it is less than 24, then we'll go towards that diagnosis.